Welcome to our Novo Nordisk Network for Healthy Populations BBDC Joint Clinical and Population Research in Progress rounds hosted at the University of Toronto. We are aimed to start at 12 o'clock and we have a full schedule, so I will get started as people are entering. So before I begin, I would like to just acknowledge the land on which we are today. So the land on, for thousands of years, Indigenous peoples inhabited and cared for this land, which I'm on the region of Peel and operates as part of the treaty lands and territories of the Mississaugas of the Credit. In particular, we acknowledge the territory of the Anishinaabe, the Huron-Wendat, the Haudenosaunee, and the Ojibwe Chippewa peoples, the land that is home to the Métis, and most recently, the territory of the Mississaugas of the Credit First Nation, who are direct descendants of the Mississaugas of the Credit. We are grateful to have the opportunity to work on this land, and by doing so, give our respects to its first inhabitants. We are all treaty people, and many of us have come here as settlers, immigrants, newcomers, and others in this generation or generations past. We would also like to acknowledge those of us who came here forcibly, particularly as a result of the transatlantic slave trade, and pay tribute to the ancestors of African and origin descent. Now, without further ado, I'd like to formally welcome all of you and thank you for attending today's seminar. Before I introduce you to today's speakers, I'd like to quickly review some housekeeping items. First, we appreciate the audience muting themselves during today's presentation. There will be an opportunity for questions at the end of each presentation. There will be two, and we will be inviting questions both through the chat box and we will use the raised hand function. If you have questions during the event that you would like the speakers to address at the end of today's session or at the end of their session, please enter them into the chat box. Lastly, please note that today's session is being recorded and we will make the recording available on the network's website that will be launching in the coming weeks. Now, for those of you who, for whom it is your first time attending these research in progress rounds, I'll just give you a little overview of what to expect. So these rounds are intended for trainees and students to give presentations and receive feedback on their research in progress. We have two speakers today. Each one will present for 20 minutes, followed by a 10-minute Q&A session. Each speaker has invited a faculty advisor who will lead off the Q&A session, and then we will open it up to the audience. So now I would like to introduce our two speakers. The first speaker is Dr. Dominika Bhatia. She is a postdoctoral fellow at Women's College Hospital under my supervision, contributing to research on the primary prevention of type 2 diabetes after gestational diabetes. Prior to this, Dominika completed a PhD in health services research at the University of Toronto through the Institute of Health Policy Management and Evaluation, focusing on examining the use of cancer preventative services among people with diabetes and other major chronic comorbidities. The title of Dominika's presentation is Predictors of Readiness for Health Behavior Change After Gestational Diabetes. I will introduce our second speaker when it's her turn to go on. Okay, so without further ado, please go ahead, Dominika.
Let me unmute myself first. Go. Oh, sorry. I think I need to do this again. Oh, can you see it? Yeah, okay. Sorry about that. Okay. So just making sure you can see the presentation of the slide. Okay, perfect. Sorry. So thank you so much, everyone, for being here today and for the opportunity to speak with you. As Dr. Lixko mentioned, I'm currently a postdoctoral fellow at Women's College Hospital, working under her supervision, and recently completed a PhD in health services research. And I have a broad interest in primary, secondary chronic disease prevention, especially in women. And the project I'll be speaking to you today about is still very much at the proposal phase, so I look forward to any feedback you might have. And I have no disclosures to mention. Overall, the focus of this presentation is to describe diabetes risk after GDM, the role of health promotive behaviors in diabetes prevention, and which factors influence health promotive behaviors after GDM. So first, just set the stage, gestational diabetes, or GDM, is a temporary condition that resolves after pregnancy. However, it's also viewed as an early marker of future metabolic issues. For example, it is associated with significant type 2 diabetes risk later in life, and about half of diabetes cases are diagnosed in the first 10 years after pregnancy. In addition, about a third of women with type 2 diabetes that ever experienced a pregnancy had GDM in the past, so it's a significant contributor to population diabetes burden. Considering the rise of diabetes in women overall, helping women avoid type 2 diabetes after GDM is an important target for preventive efforts. Considering who is more likely to get type 2 diabetes, lower socioeconomic status, which could be measured using education level, income, occupation, as well as being an ethnic minority, are all risk factors for future diabetes. And the mechanisms for this are complex, multifactorial, and remain to be well understood. On the other hand, engaging in certain health promotive behaviors may substantially reduce diabetes risk. For example, some observational studies have shown that increasing physical activity after GDM reduce type 2 diabetes rates in the future. Likewise, in interventional studies, diabetes preventive programs, which include diet and physical activity modification, nearly halved type 2 diabetes risk in higher risk populations, including women with previous gestational diabetes, and intervening in the first 3 years early in the postpartum period for women with gestational diabetes has shown to be most effective. The focus of this study is to answer the question of among women with GDM, which factors are associated with health promotive behaviors in the first 2 years postpartum. I'll be talking to you a bit about kind of early results from a mini analysis, and then I'll talk further about next steps about the broader analysis and what we expect to find from the study. So the data source in the study is going to be a cohort of Toronto women who were recruited in pregnancy from 7 Toronto hospitals. The data collection involved 3 surveys administered in pregnancy and in each postpartum year, so first year postpartum and second year postpartum. And in pregnancy, the survey, as well as chart reviews, collected a broader set of information on sociodemographics, clinical history, as well as health behaviors and psychosocial factors. And then the subsequent surveys focused on health behaviors and psychosocial factors.
Can you speak up a little bit? It's hard to hear a little
absolutely. Bit. Sorry. In the preliminary analysis that I'll be presenting next, we considered women who completed all the data points or data collection points in the study. So that includes the chart reviews, the in-pregnancy survey, and then the first and the second postpartum surveys. And we consider the 2 time periods for postpartum, the first year and the second year, because there could be some differences in maternal leave, as well as just adjustment to motherhood that could affect health behavior engagement. We considered sociodemographic, clinical, and psychosocial factors that may influence health behaviors. The sociodemographic factors and clinical factors were collected from charts and in-pregnancy survey, as shown earlier, and the psychosocial factors were collected from the 2 postpartum surveys. In terms of the outcome, we considered engagement in health promotive physical activity and diet behaviors in the first 2 postpartum years collected through the postpartum surveys. And specifically in the surveys, women were asked to rate their current diet and physical activity, or to note their current diet and physical activity behaviors, and then also rate their intentions for whether they plan to continue engaging them, or whether they plan to, if they haven't been engaging, to begin engaging. These ratings were dichotomized for the purposes of this analysis as women who were already engaging in health behaviors and those who were not. And here are some preliminary findings. So overall, fewer than half of women reported engaging in health promotive behaviors in the first 2 years postpartum, both for diet and physical activity, but with lower engagement in health promotive diet behaviors. There's little difference from the first to second postpartum year, and a few women changed who were not adopting health behaviors in the first year switched to adopting in the second year. And then in regression models, being an ethnic minority was associated with lower likelihood of being physically active in either first or second postpartum year, whereas self-efficacy and social support were associated with higher likelihood of being physically active in either postpartum years, first or second. And then looking at diet, only self-efficacy was a significant predictor of health promotive diet behaviors, whereas none of the other factors considered were significantly associated with diet behaviors. So in terms of where we'd like to take the study next is we'd like to investigate whether engaging in health promotive behaviors is a mechanism that connects individual characteristics like social determinants of health and future type 2 diabetes risk in women with prior gestational diabetes. We are able to do so because we have an opportunity to link the cohort that we have with the survey and the chart data to administrative health service data housed at ICS that includes clinical services and also new diagnoses for these women. And we can do this linkage using health card numbers available and follow them to present time. So this means that we have about 10 years follow-up since the time of pregnancy to identify new type 2 diabetes diagnoses. And we can use the Ontario Diabetes Dataset that's available at ICS that has a robust and validated definition for identifying new cases. Just looking at the numbers, so most women consented to have their health card number linked to administrative data. So this will be a fairly comprehensive cohort. And since, as shown previously, there were minimal differences in health behaviors between the first and the second postpartum surveys, we will take women that completed either of the surveys, so either the first or the second, to increase the sample size. This analysis will enable us to not only observe the relationship between social determinants and type 2 diabetes risk, but also identify a possible mechanism through which health promotive behaviors may contribute to diabetes risk. An analytic approach that can help us derive this relationship is through causal mediation analysis, which will decompose the effect of social determinants into a direct effect on type 2 diabetes diagnosis and an indirect effect, which is could be attributed to other factors like health promotive behaviors as a possible mechanism. So overall, from this preliminary analysis, we've shown that fewer than half of women engaged in health promotive physical activity and diet behaviors after gestational diabetes within the first 2 years postpartum, which is an important window that could, if engaging in health behaviors, could prevent type 2 diabetes within this window. In terms of specific characteristics associated with lower engagement, we saw that non-Caucasian ethnicity was associated with lower likelihood of engaging in physical activity in either postpartum year, whereas social support was associated with higher likelihood of engaging in physical activity in either year. Notably, self-efficacy was associated with increased likelihood of both engaging in healthy diet and physical activity within both postpartum years. And linking survey and admin data provides us with an opportunity to understand the contribution of this engagement in health behaviors towards long-term diabetes risk 10 years after pregnancy. Some limitations to note about this design are that First, we're using self-report data from surveys, which risks recall bias or social desirability bias, where people may over-report how much they engage in physical activity or healthy diet, or they may not recall accurately their engagement. There's also a possible risk of time-dependent bias for the longitudinal analysis, where we're considering type 2 diabetes as an outcome, because people may modify their health behavior later on after the first 2 surveys where we asked them about their health behaviors. And so that could also modify their type 2 diabetes risk. Nonetheless, since as shown previously, there's evidence that behavior changes are most effective in the first 3 years postpartum, the findings of the study are most actionable and relevant to the health system, because women are more in touch with the healthcare system during pregnancy and afterwards, or in the short window afterwards. And so this is a window when we can actually support them to adopt health promotive behaviors. As with any observational study, there's some risk of residual confounding. Some factors that I didn't mention as being measured could confound the relationship between social determinants, health behaviors, and type 2 diabetes risk. And that's something that we'll need to consider when we retrieve administrative data and identify any potential additional factors, like maybe subsequent pregnancies that were complicated by gestational diabetes. And finally, generalizability of this sample. So people who may participate in research, especially those who participate in multiple phases of research, may also be more likely to value health promotion and have higher health literacy. And so they could be different from the general population of women with gestational diabetes. And so that's another factor to consider and potentially compare with the general cohort of women with gestational diabetes using ICS data. It should be noted that there are many reasons why women may not be able to engage in health promotive behaviors after gestational diabetes. And they may span multiple levels and include competing demands, mental health issues, changes in family roles and limited social support, as well as health system issues like inadequate supports to make health behavior changes, and the broader public policies and community characteristics. While the study will identify targets for intervention to better support women with gestational diabetes, health behaviors are just one component, and they need to be embedded within a comprehensive approach that spans the health and social systems to foster environments where there are few barriers to engage in healthy lifestyles, like adopting physical activity and diet behaviors, which could include mat leave policies and built environments that are more conducive to exercise. In addition, in terms of promoting health behaviors, interventions like health coaching and patient navigation, individualized supports could better address the individual barriers that women experience and support them in making the changes early in the postpartum period to prevent their risk of diabetes. And thank you to all the other investigators and folks involved in creating this data set. And thank you for listening.
Thank you, Dominika. That was very well done. So I'm going to open it up, and maybe I'll start with Dr. Faig. If you have any questions or comments, please.
Hi.
Hi.
That was a great presentation. And I enjoyed reading your abstract. So would you consider this a mediation analysis? And if so, how is your mediation analysis going to differ from a regression model?
Yeah, so the goal would be to take this to a mediation framework. And so to my understanding, to be able to implement a mediation analysis, we need to understand relationships between both the social determinants and type 2 diabetes, as well as social determinants and the potential mediation factors like health promotive behaviors, which I've done here in a preliminary analysis, and then also health promotive behaviors and diabetes. So those would be kind of the initial regression analyses to identify those relationships. And then the subsequent step would be to build those into a mediation framework.
And have you decided what kind of, like, how you're going to do the mediation analysis? Like, I believe it's the analysis is different than a plain regression model, right?
Yeah, so that remains to be determined in terms of the details, but essentially we would build regression models looking at those individual relationships between the exposures and the mediators and exposures and the outcome, and then look at the contribution of how much adding the mediators into the model might explain the relationship between the exposures and the outcomes. And another consideration is also confounding. So each of those three-way relationships could have unique confounding. So that's another kind of step before we can actually proceed with mediation.
Yeah, I think it's a really important and interesting project because you're trying to identify the mediators that are modifiable, right?
Mm-hmm.
So I think it's a really great project. Have you considered depression as either a socio-demographic factor or a mediator?
Yeah, I think that'd be very important. And we do have information about depressive symptoms experienced during pregnancy and postpartum in the survey. So that would be a key covariate to consider.
Okay, great.
Thank you, Denise. So Dr. Kramer, go ahead. Thanks for joining.
Hi, Lorraine, and hi, Monica. That was a great presentation, and it's a very relevant topic as well, right? As we all know. I just have a suggestion. We were talking about regression analysis and mediation analysis. I'm not sure if that's applicable to your data set, but one thing that you can consider is doing a principal component analysis. They use that in psychiatric studies because behavior is usually a combination. It's so difficult to kind of tease what exactly is driving that. And I think that it's very complicated. I don't know how to do it, but I just know that it is used in behavioral studies. And then you can kind of put as you create a set of components, then you can put all of the variables that you think, including like what kind of health support the patient has. Let's say for patients post-GDM, what kind of facilities for physical activity they have around, neighborhood walkability. And then there is a way that you can kind of rate which components are more important for that particular behavior. But again, I'm not sure if you can do it with your data set. I think you can, but it's just something that maybe you want to consider that it can give you a very nice result. But it was a great presentation.
Great. Thank you so much. That's really helpful.
Yeah, we can. Thank you, Carolyn. I think we can look into that. I think it's a great way to think about it, sort of that attributable, but a little bit more complex than attributable fraction. Any other questions or comments for Dominika? Great. Dominika, thank you so much. That was great. I hope it was helpful for you to get some feedback. So I'm just going to minimize my screen so that I can find. Okay, so why don't I now ask you to join me in thanking Dominika for an excellent presentation, and we will move on to our second speaker. And I will start by introducing her. So our second speaker is Laleh Rashidian. And she is currently a second-year PhD student at the Institute of Health Policy Management and Evaluation at the University of Toronto, under the supervision of Dr. Walter Wojcik, who's with us today as well. Laleh combines her clinical background and research skills toward responding to key questions related to the quality and delivery of care provided for diabetes patients across Ontario. She also is living with type 1 diabetes. And the title of Lale's presentation is Diabetes Access to Care During the COVID-19 Pandemic Across Ontario Health Teams, Insights from Population Data in Ontario, Canada. So without further ado, please join me in welcoming Lale. Thank you for presenting today.
Thank you so much, Lorraine. I'm very happy to be here. Allow me to share my screen. Does this look okay? Yeah. Okay. Hi, everyone. I'm very happy to be here. My name is Lale Rashidian. I'm a PhD student at IHPME, and I'm looking forward to presenting my ongoing research on diabetes access to care during the COVID-19 pandemic using population data across Ontario and across Ontario health teams. So I'm sure everyone who's here today is well aware of the importance of diabetes mellitus. And so I'm just going to touch on a few quick points before we dive into the work itself. In 2022, we had over 1.5 million patients with diabetes in Ontario. And one thing that we've seen based on previous research is that diabetes management and diabetes care is impacted by inequity. Now, what does that mean exactly? What that means is poorer populations, lower income populations have higher rates of diabetes, they have poorer glycemic control, and they have increased rates of complications, which sounds a bit bleak. But the good news is that if we're able to get patients to improve their disease management, improve their access to care, research has shown that they have improved quality of life, increased life expectancy, and decreased probability of complications. So before going into the research question itself, I'm going to talk a bit about Ontario health teams. And the reason for this is that we're looking at diabetes access to care in the context of Ontario health teams. So it's good to know what we're talking about here. Ontario health teams are a new model of healthcare delivery. They were first implemented in 2019. And what this model of healthcare delivery does is it puts patients, families, and caregivers at the center of the healthcare system. The point of this is to improve coordination of care and services for patients and their families and caregivers across multiple care settings. So within the geographic area of the OHT, which includes hospitals, healthcare providers within that geographic area, hospitals, doctors, and home and care, community care providers, they work together as one coordinated team. And these OHTs, they have an attributable population, and they have fiscal and clinical accountability for that population. And at the moment, we have 53 OHTs currently in place across Ontario. So our research objective today is to measure access to care for diabetes patients across Ontario health teams from 2019 to 2021 and determine whether access to care for these patients was affected by the COVID-19 pandemic. I was also interested in looking at inequities in access to diabetes care across Ontario health teams. So how we did this was using longitudinal data that was accessed from administrative ICES databases. So we looked at certain diabetes indicators, which we'll go into in detail in a bit, before and after COVID-19 across the Ontario health teams. And also we looked at the correlation of these diabetes indicators with material deprivation, which is a marker of inequity, which we'll talk about also. Okay, so we had a couple of hypotheses going into this. Firstly, that access to care for diabetes patients would be negatively impacted following the COVID-19 pandemic, and that these disruptions in access would be greater among more deprived socioeconomic groups. Okay, so we looked at 5 diabetes indicators in this research. So the first 3 indicators, the proportion of patients that are up to date with HbA1c screening, the proportion of patients that are up to date with their retinal examinations, and the proportion of patients that have had statins dispensed. These are all related to diabetes management. They are not diabetes outcomes per se, but they are process measures, not outcome measures. Whereas the last 2, hospitalizations for long-term diabetes-related complications, and the proportion of patients that have HbA1c levels equal to or greater than 7, meaning that diabetes is not in control. These 2 are considered outcome measures, and they've been in the results, the preliminary results that we'll present in a bit. We will present risk-adjusted data for these based on age and sex, so that we can better compare our OHTs that have differing populations. So we will be looking at all of these indicators through an equity lens. So the marker of equity that we use here is the Material Deprivation Index. This index is based on Canadian census data from 2016. It looks at things like education, income, housing quality, and family structure at the level of the dissemination area, the level of around 400 to 700 individuals in the population. And what it tells us is, it tells us whether or not people are able to attain their basic needs. It's been closely linked to poverty and access to care, and also health outcomes. And the way this data is reported is the data is split into quintiles, with the first quintile being the subgroup of the population that are least deprived, moving through to the fifth quintile, which are the most deprived subgroup of the population. In this image that we see here, we have the most recent year of data for all the Ontario Health teams, either 53 little rows here, and they have been stacked. So at the top, we have an OHT that has, if you look at the dark blue is representative of our most deprived subgroup in our population. They have almost 1/3 of their population in the most deprived subgroup. Moving all the way down to the bottom, we can see that some OHTs here at the bottom have almost half of their population in the light green, which is the least deprived. So as you can see, it's a very different makeup regarding material deprivation across Ontario Health teams. So this style of data representation will be coming up a few times in this presentation. So I'll spend a bit more time on this slide just to show you what data has been presented here and what we can learn from it. So here we're talking about the prevalence of diabetes across Ontario Health teams, meaning the proportion of people over the age of 18 that have type 1 or type 2 diabetes. Each of these colored dots represents an individual OHT, and they have been sorted with more desirable values, in this case, lower prevalence of diabetes on the left, all the way to the right, where we have the less desirable or higher prevalence of diabetes. The dotted line that we can see in the top panel is representative of the average across Ontario. So with the prevalence of diabetes, we have an average of 13% prevalence across Ontario, but this ranges from around 9% to 16% across the different Ontario Health teams, meaning we have an almost twofold difference in the prevalence of diabetes in different Ontario Health teams. This means that we have high variability. And also, if you look at the dark blue dots, so these are representative of our more deprived OHTs. They seem to be more clustered towards the right. So we have barely any dark blue over here on the left. And this coincides with a moderate correlation with deprivation. We have a correlation of 0.5. Moving to the bottom panel, now this panel, it looks at prevalence of diabetes not across OHTs, but within OHTs. So what this says is for each individual OHT, it looks at the most deprived subgroup and the least deprived subgroup, and it compares the thing we're measuring, in this case prevalence, in those two subgroups, and it gives us a ratio. So if within an OHT, we have the same prevalence of diabetes in our most deprived and our least deprived subgroups, we would have a ratio of 1, and it would fall on the dotted line. Whereas if it's above the dotted line, then we have a higher prevalence of this indicator, in this case, prevalence of diabetes, in our more deprived subgroups within each OHT. As you can see here in the bottom panel, almost all of our OHTs are above that dotted line. That means that even within these individual OHTs that have different prevalence of diabetes, they have higher rates of diabetes within their more deprived subgroups compared to their less deprived subgroups. It's not moving to the next one. Okay. In this slide, we're just looking at very preliminary data. There's not a lot of detail on here, but reflecting how our 3 process measures, if you recall, we have HbA1c screening, retinal screening, and the proportion of diabetes patients with statins dispensed from 2019 through 2021. So if we start here on the left, we have HbA1c screening. As you can see, in 2019, it was over 50%. In 2020, with the advent of the COVID pandemic, this has dropped down over 10% across all 5 of our quintiles. And this has recovered somewhat in 2021 compared to 2020, but it's still not at the level that it was prior to the pandemic. And another thing we can tell here is each of these different colored bars represents one of our income quintiles, deprivation quintiles across our population. So as you can see, they seem to be pretty much around the same level. There are differences in cost quintiles, but it's not a certain pattern. It's not a slope per se. And this is repeated across all 3 years. So that doesn't seem to be that certain income quintiles are disproportionately affected regarding their HbA1c screening. In the middle, we have our retinal screenings, or the proportion of patients up to date with retinal screening. So in 2020, we see a drop compared to 2019, and it's continued to drop in 2021. Again, we're looking at across our quintile, so Q1 through Q4, they seem to be pretty much the same. Q5 is a bit lower, but again, there's not a distinctive slope observable here. On to the right, we have the proportion of patients with statins dispensed. There doesn't seem to be much of a change based on this data across the 3 years. It seems to be relatively stable, and also across OHTs, we don't seem to have a slope. So diabetes control, these are our two outcome indicators. So we had the percentage of proportion of patients with HbA1c levels greater than 7, meaning like not good control versus good control. And we also have long-term diabetes related hospitalizations. So on the left, we have looking at good diabetes control and not good control. One thing that you can tell is that the proportion of patients with good control and not good control, both of these have dropped in 2020 compared to 2019. Now that might seem counterintuitive, but basically what it means is that because missing data is included in this, it means that less people have gotten their HbA1c tests done in COVID, which aligns with what we saw in the previous slide. So we have an increase in our missing data. Both of these have gone back up to some extent in 2021 compared to 2020. But here we have a slope. We have a slope that's observable both in good diabetes control and in not good control. So if you're in Q1, if you're in the least deprived subgroup, higher proportions of people have good control. Again, when we look at not good control, those in Q5, the more deprived subgroups, high proportions have not good diabetes control. Moving on to diabetes-related hospitalizations. So just one thing to point out is that the range here is from 0 to 3%. So these aren't huge numbers, but still we have a clear observable slope. So across all 3 years, we have higher rates of hospitalizations for diabetes-related complications in our most deprived subgroups of the population. And over the years, there doesn't seem to be a huge difference in hospitalization rates. So not a lot of impact from COVID, just based on this graph. Now we'll touch on each of our individual indicators. So we have HbA1c screening. So the definition for this is the proportion of patients with diabetes over the age of 40 who are up to date with HbA1c screening. Up to date meaning they have had 2 or more HbA1c tests within the past year. So the average for this was 47% across the Ontario health teams, ranging from 30 to 56%, so almost twofold. And that's and high variability across our OHTs. The dark blue points representing the more deprived OHTs, they seem to be that they're spread throughout. There is a weak correlation with deprivation, so we don't see clustering of the dark blue. And in the bottom panel, when we look at HbA1c screening within OHTs, most of our OHTs seem to be spread on that dotted line, meaning that the proportion of patients up to date with screening is relatively the same in our most deprived versus the least deprived subgroups. Retinal examination. So the proportion of patients up to date with retinal examination, these are diabetes patients over the age of 40, and these are patients who have had at least one retinal examination within the past 2 years. So it's not 1 year in this one. And the average for this is 61%. It ranges from 55 to 71%. Again, we have high variability across our OHTs. The dark blue points are spread throughout. There's a weak correlation with deprivation. We don't see clustering. And again, in the bottom panel, as you can see, they seem to be fairly clearly spread out, just, on that dotted line. There's not an observable like drop below the line or higher above the line in this indicator either. Statins dispensed. These are the proportion of our patients with diabetes over the age of 65, so this is based on Ontario Drug Benefit Program, that have had statins dispensed within the past year. So the average for this is around 72%. It ranges from 61 to 76. Again, we have high variability across our OHTs, but it's good to point out that we do have a couple of outliers there on the right, if you can see. And moving on to our bottom panel, they're just sitting like ducks in a row pretty much on that dotted line. And so our patients getting their statins in our most deprived subgroups and least deprived subgroups seem to be pretty much the same proportion within OHTs. Now we have our two outcome indicators. So these are the proportion of patients with diabetes over the age of 18 who have had at least one hospitalization for a long-term diabetes-related complication within the past year. So this is looking at people who are hospitalized for amputations, blindness, kidney failure, etc. And this one is risk adjusted based on age and sex. So OHTs with different population, composites can be compared to each other. So the average for this is around 2%. This ranges from 1.3 to 6.2. So more than fourfold difference in hospitalizations across these different OHTs. Although it's good to take notice that we do have an outlier there on the right that is impacting this range. And we have high variability in hospitalizations across our OHTs, and there seem to be more of the dark blue on the right. It's not a huge correlation, but we have a weak to moderate correlation with deprivation. It's a correlation of 0.28. Now looking at the bottom panel, you can see these are not all sitting along the dotted line. So what this means is within each of our OHTs, hospitalizations are happening at much higher rates within our more deprived subgroups compared to our least deprived subgroups. And onto our final indicator. So this is the proportion of patients with diabetes over the age of 40 with HbA1c levels greater than or equal to 7, meaning they're not in good control. And again, this has been risk adjusted based on age and sex. The average is around 38%, ranging from 31 to 57%, so almost twofold difference in patients with poor control across OHTs. And dark blue again, there's more of the dark blue on the right. There seem to be like very few dark blue points on the left of this graph. So we have a weak to moderate correlation with deprivation. The correlation here is 0.3, high variability across our OHTs. And in the bottom panel, we can see most of our OHTs are above that dotted line. So again, within these OHTs, we have more patients in more deprived subgroups are not in good control of their HbA1c compared to less deprived groups. To summarize, diabetes management is moderate overall. We have 47% of our patients who are up to date on the 2 HbA1c tests within the past year, 61% who are up to date on retinal screening, and 72% who have received the recommended statin therapy. And if you recall, with the 3 process indicators, so the HbA1c screening, the retinal screening, and the statins, they seem to be, if you call the bottom panel, they were all in line. There was little evidence of inequity in accessing diabetes management services across quintiles. However, we did observe inequities in our health outcomes, meaning that patients from our more deprived neighborhoods had higher hospitalization rates for diabetes-related complications and higher proportions of uncontrolled diabetes. So the question that comes to mind is this: since we don't seem to have a huge amount of inequity in diabetes service provision, why do we have inequity in outcomes? In the future, during my PhD, I hope to look at the following research questions in my thesis. Firstly, I want to look at whether the variation that we observe across OHTs is meaningful, or if this variation can simply be attributed to random variation. Secondly, I want to see to what extent HbA1c control is driven by factors at the patient level, at the physician level, or at the OHT level. And also, I want to see how these factors are affecting inequity in HbA1c control among different OHTs. So to do this, my target population will be adult patients with type 1 or type 2 diabetes who will be identified through the Ontario Diabetes Database. And this data will be linked to other administrative databases, which I've listed below. We'll be collecting data from fiscal year 2019-2020 through to 2021-2022. And basically what this data will do is it will allow us to obtain demographic information on patients through the registered persons database. We will be able to measure how these patients have been using healthcare services through OHIP records, and also just looking at outcomes such as hospitalizations and laboratory measures, which will be obtained through the DAD, the NACRS, and the OLIS databases. So for my first research question, whether there is meaningful variation among OHTs, I hope to use small area variation analysis methods. And so basically this will look at the extremal quotient, showing us the magnitude of difference across OHTs, the ratio of the 90th percentile to the 10th percentile, which again, it will show us magnitude of difference once we remove the outlier, so the 10% and the 90%, and also the coefficient of variation. And Using this, we'll be able to assess geographical variation across OHDs by removing the random component from the variance. For the second research question, finding out to what extent HbA1c control is driven by patient, physician, or OHD level factors, the outcome of interest will be HbA1c control, so the HbA1c levels themselves. And to do this, hopefully I'll use hierarchical linear modeling to analyze data on the 3 levels that we mentioned before. And intraclass correlation coefficients will show us how much of the variation in HbA1c control is attributable to each level, how much of it is because of patient differences, how much of it is physician differences and OHD differences. And once we determine how much of the variance is because of each level, we will add covariates in a stepwise manner to each level. Some of the covariates we'll be using are listed below. This list isn't exhaustive, but for key patient level covariates, we have age, sex, Charlson comorbidity score, and baseline HbA1c. For physician level covariates, we have physician age, sex, specialty, and accessibility, such as in-person visits, virtual visits, etc. And for OHD level covariates, some things we'll be looking at are material deprivation quintiles and the number of physicians per 1,000 population. And for the final research question, looking at inequity across OHDs, but the method will be similar to the previous research question. So again, I hope to use hierarchical linear modeling and look at factors driving this at patient levels, physician levels, and OHD levels. But this time, the outcome of interest won't be HbA1c levels themselves. It will be the slope index of inequality in HbA1c. And what the slope index of inequality does is summarizes the relationships between a continuous outcome measure, which in this case is HbA1c values, and an ordered categorical measure of social position, which we have our material deprivation index quintiles. So just to wrap up, in order to achieve diabetes management, we will have to be able to reach those individuals who are not up to date with their screening. And also, while accessing care is important, we have to make sure that the care that patients access is effective care. It is highly likely that there's more to reducing diabetes-related complications than just diabetes management, and social determinants will likely play a role here. And over the course of my thesis, I will hopefully look at the drivers of good and poor diabetes-related health outcomes across OHTs in Ontario. Thank you, and I'll appreciate any feedback, questions, or suggestions.
Lale, what a lovely presentation. Really well done. Congratulations on this amazing body of work. I think you've got a lot of great questions there. So now we'll open it up to questions, and we'll start with Dr. Shaw, who's agreed to be the faculty advisor today.
Thanks, Lorraine, and thanks, Lale. That was a really excellent presentation. You know, it's difficult to kind of convey a lot of that information. There's so much data, but I think the way you presented it and explained it was really effective and made it very easy to follow. So thank you for that. You know, your observations about the changes that happened during the COVID pandemic sort of fit with what you might have expected to be there, right? That, you know, continuing on your prescriptions is easy. You could just go to the pharmacy and keep getting your drugs, and that was easy. Whereas actually going to the eye doctor and all that was much more difficult during lockdown. So those are the ones that were really depressed quite a bit more. I noticed that for much of your thesis work, you're planning on looking at the A1C control part of that outcome is really going to be the most important one. And you did observe that there was a drop off in A1C testing during COVID, which is starting, or, you know, the height of the pandemic, which is starting to recover. Have you thought about how that is going to impact on those sorts of analyses that you want to do? And so specifically, like you showed, in control and out of control, and both went down because the amount of missing data went up. So how are you going to deal with that? Because I guess I want you to maybe think about why is the data missing, and is it going to be missing differentially across different groups?
That is an excellent question. I think the reason we selected HbA1c control as the outcome was that, like you said, it's COVID and everything is being impacted by COVID. And I was thinking, like, if I selected an outcome such as hospitalizations, it would be much more likely to be affected by a myriad of other things that were going on during COVID. And whereas the HbA1c levels, the good thing about these is that these aren't hospital HbA1c tests, these are outpatient hospital HbA1c tests. So I was hoping there would be less of a disruption as a result of COVID in this. But regarding how I'm going to think about, that's an excellent question. I'll have to do some thinking about that. Thank you very much.
Yeah, I mean, I guess my point is that you know, I would suspect that missingness is going to be greater in those more deprived areas and in more deprived populations in whom, you know, the impact of COVID was a lot more as well. I mean, that might be something that's worth exploring is you know, what are the differences by OHT based on their burden of COVID in each OHT, and see if that has also influenced the ways in which A1C testing rates declined or did not decline. I think you want to be careful about choosing either greater than or 7 or less than 7, but using everybody as the denominator versus just those who had a test. Because, you know, what's the right answer? I'm not sure I can say, but I think just be careful about, you know, the proportions overall went down, but if the relative proportion actually didn't change, then maybe it doesn't mean anything. But you do need to think about that.
Thank you very much. Definitely take that into account.
Do you have any other comments or questions, Beju?
No, I don't. Well, I mean, we can let other people ask questions.
Sure,
and
sure.
I'll come, if there's more time, I can ask.
Great. Okay, so Lale, there were a couple of a few questions in the chat. I'll start with the first one. How did you decide on which indicators to include?
So the first 3 indicators we selected, the HbA1c screening, the retinal examination, and the statins. These were selected to align with the primary care reports that the ministry released to primary care physicians. So they were provided with reports on these 3 indicators regarding the diabetes care they provided. So these 3 were selected to align with those. And we just wanted to include a couple of outcome measures to not just be looking at process indicators and have outcome measures as well. So in HbA1c, and hospitalization for long-term diabetes related complications seem to match the outcomes we were looking for here.
Terrific, thank you. And Lele, the second comment was, I think it was more of a comment, or just a question, maybe something for you to consider, that for your thesis work, OHT contribution to process and outcome measures, there may be additional measures that you could try to capture. For example, whether the OHT has a formal clinical program, dedicated staff, booking and scheduling solutions. Obviously, I'm aware, many of us here are aware that there are limitations to the administrative database administrative data that are available to us. But maybe you could comment a little bit about other variables that might be of use to kind of get at some of those subtle differences in access to care. And along the same lines, the other question was related to that is like whether, and you know, maybe you could share with the audience this, that whether there would be any availability of data around time in range and time out of range. I mean, obviously we know that for those of us who do diabetes management, that's quickly becoming an alternative way of checking diabetes control, but we don't really have it in the administrative data. Maybe you can comment a little bit about those different data points.
Yeah, happy to. Regarding Mark's comment, I think these are excellent things to take into account regarding OHT level, covariates for the multi-level modeling. I think the number of dedicated staff, etc., we should be able to access that from the administrative data. But regarding booking and scheduling, that will probably be a bit more difficult to access from the databases that we do have. And regarding the time in range versus time out of range that Krista mentioned, well, because the HbA1c only looks back 3 months, as we all know, and the definition of being up to date on HbA1c screening only requires having 2 HbA1c tests within the past year. So at most, we're looking at 6 months out of the year here. But it might be a good thing, and I am thinking about this, to redefine how we redefine having being up to date on HbA1c to have like at least for to make sure that we are covering the whole year, so we can look indeed at time in range versus time out of range and be able to report on that.
Thank you, Lale. And maybe I'll just finish off with one last question from Ghazal. She says, fantastic body of data to explore further. I wondered if you have access to immigration data, race, ethnicity, in addition to SES, to be able to determine which populations face the greatest disparities in access to care.
The data on race ethnicity, to the best of my knowledge, is covered in the registered persons database, so we should be able to access that. I'm a bit more unsure about the immigration data, but I do know that Dr. Baiju has done excellent work on an algorithm on which to identify ethnicities of individuals based on surnames. I'm sure something like that could be very well integrated into this with amazing results.
So thanks for that, Lali. Maybe I'll ask Ghazal, do you want to, I don't want to put you on the spot if you're not available, but do you want to comment on the immigration data? Because I know you did your PhD using that data.
Yes, no, I was just going to write in the chat the IRCC. So if you're already linking, so the registered persons would not be able to provide that, but the IRCC definitely will, as well as you mentioned, the surname algorithm. If you are able to look at that, that would be fantastic, just to see which populations are facing the greatest disparities.
Thank you so much.
We know that, yeah, and we know that diabetes, you probably are aware that it's disproportionately affecting our immigrants in some, at least in some areas. And the nice thing about the IRCC, it doesn't just tell you if someone's an immigrant, but also where they're from. So that might be interesting too. And Beju, did you want to comment on the surname algorithm?
Yeah, I mean, I think it's an effective way of being able to identify a specific population. It's not sensitive though. So I mean, those are the caveats that we need to remember, but it's a good way to identify South Asian populations and Chinese populations, and it includes, you know, non-immigrants who were born here or who wouldn't otherwise be captured in the immigration data. So that's another possibility. But, you know, each of these is measuring slightly different things, right? So you have to figure out how you're triangulating it properly and that you're describing what you're actually measuring accurately.
Thank you very much.
Wonderful. Does anyone else have any other questions for Lale? If not, I would like to ask everyone to join me in thanking Lale for an excellent presentation, and also for our first speaker, Dominika, as well, for her excellent presentation. I'd also like to thank those of you who agreed to be her faculty advisors, Dr. Denise Faig and Dr. Beju Shah. We really appreciate your time and input. This is, I know, is always very highly valued by our trainees as they're getting started on their research programs. So this concludes today's seminar session. So I'd like to once again thank our speakers today and thank everyone for joining. And just to let you know that we've put in a where is it? A survey for you to do today's evaluation in the chat. And just to let you know that our next event will be very exciting. It's going to be on March 20th, 2023 from 12 to 1. And we will have Dr. David Campbell speaking. He is an endocrinologist and clinician scientist from Alberta who's doing some great work around food insecurity and diabetes. And he's also done some work around diabetes and homelessness. So I'm not sure what he's going to speak about yet, but please join us and we will be sending details closer to the date. Thank you everyone for joining, and I hope you have a wonderful week.